Hello and welcome to ESC TV. Today we're talking about the Hotlines 2 late-breaking clinical trials session, and we're lucky to have with us Professor Gilles Montalescot from the Department of Cardiology at Poitiers-Salpêtrière University Hospital in France. Professor Montalescot, welcome. You're presenting results from the comparison of prasugrel at the time of percutaneous coronary intervention or as pre-treatment at the time of diagnosis in patients with non-ST elevation myocardial infarction, or the ACCOAST trial. So maybe if you begin by giving us a little bit of background to the study. That's okay.
Yes, it's pretty simple. The current guidelines from the European Society of Cardiology say that we should give a pre-treatment with a P2 white valve antagonist to all patients presenting with non-ST elevation acute coronary syndrome. And it is a class 1 recommendation. It has been a class 1 recommendation for many years. And this is based on two old studies performed 15 years ago with an old drug, which is clopidogrel, a generic now. And we have absolutely no data for the new P2 white valve antagonist in the modern era when the patients go to the catheterization laboratory very rapidly. You may remember that in CURE, they went to the cath lab 10 days after waiting in the CCU. Here, on average, in ACCOAST, they went to the cath lab 4 hours after admission. So it's a different scenario. It's a different drug, more potent, more rapidly active. And the expectation was that we would have also benefit from pretreatment with prasugrel, a new P2 white valve antagonist, compared to a treatment given after the coronary angiogram when you are sure that you're going to have a PCI performed. And the results actually contradict the hypothesis. There was absolutely no benefit on the ischemic side, which was the primary endpoint of the study. Absolutely no trend, no hint of benefit. And there was an excess of bleeding. We observed a twofold increase of major bleeding, TIMI major bleeding. And when we looked at non-CABG related bleeding, those that are important to the cardiologists, there was a 6-fold increase in life-threatening bleedings. So the picture is quite clear. We have a study that challenges the current guidelines and the current practice. And we need to reevaluate the guidelines and our practice, and probably imagine now to wait to see the coronaries before treating these patients with one of these drugs.
So what do you think the next stage is for future studies to try and answer some of these questions?
I mean, the next step would be to go to STEMIs, which is a different scenario, a different situation, and we may expect a different result. And the evaluation of this type of drug should be done also in STEMI patients. It has not been done yet. There is one study ongoing, which is the Atlantic study, another European study. And we should be able to present this study next year.
ESC Congress 365 is your free access to ESC Congress content all year long.